guys, Ruth here, stroke nurse at RUH. I wanted to come on today and talk to you about the switch from TPA to TNK when treating stroke patients with IV thrombolysis. So why have we made the change? Number one, alteplase is a real pain in the butt to give. We all know that you drop a bolus dose, which is 10% of the total dose, and then you have to program that pump to run the remainder as an infusion. TNK is beautiful in that it's only a bolus dose, so much easier to give. How do they differ? Well, TNK is just a genetically modified form of alteplase. With this modification, what has happened is it has become more fibrin specific, meaning that it really targets the fibrin which makes up the clot a little bit better than TPA. It has a longer half-life, so it's actually in the patient's system longer, doing its clot busting activities. And again, there's no infusion. So this makes it so much easier, especially for patients who are being given IV thrombolysis in the periphery and then needing to come into Saskatoon for mechanical thrombectomy. Instead of drip and ship, we can now just give and go. So this is why we've really made the change. So who is eligible for tenecteplase or TNK? You know what? Same people that were eligible for TPA can get TNK. The eligibility criteria is the exact same. And there's only 3 absolute reasons a patient can't get TNK. Number 1, intracerebral hemorrhage. That's why we need the CT first. Number 2, bleeding from a non-compressible site. So bleeding somewhere in the body that you can't put pressure on to stop the bleeding. And number 3 is the patient is last seen normal outside that 4.5-hour window. And truthfully, even that has a bit of wiggle room with advanced imaging. Otherwise, there's quite a lengthy list of relative contraindications, but that will be up to the neurologist to discern whether, if a patient has one of these relative contraindications, if they'll still be eligible for TNK. So when you're going to give TNK to your patients, there's a few things you're going to want. You're going to want the order set, you're going to want the cardiac monitor, and you're going to want to take the blood pressure right before the TNK is given, because there are quite strict blood pressure parameters. You don't want your patient to have a systolic over 180 and a diastolic over 105. So you've gotten the physician to fill out the order set. When you're looking or considering dosing, it is a weight-based drug, and you have about 20 pounds to play with, so we want you to estimate what the patient's weight is. For example, if the patient weighs between 60.1 and 70 kilos, the dose is 17.5 milligrams or 3.5 mils. So you have a lot of guessing, a lot of wiggle room in terms of when you guess the patient's weight. Okay, let's go ahead and try drawing this baby up. Now, if we weren't a publicly funded health care system, I would actually draw it up, but because this thing costs $2,400, we're just going to use our imaginations. So what comes in the kit? Number 1, sterile water. Number 2, the TNK powder. Number 3, this little 10 ml syringe. So it's very easy to reconstitute. You draw up the sterile water, then you're going to inject it into the powder. A tip and trick I've found is that if you inject it down the side of the vial, there's less chance of the drug foaming, and it actually breaks down the drug quicker. If you forget and you put it directly into the powder, you'll just need to let it sit for 2 or 3 minutes to actually dissolve. After you've put it in, you want to gently rotate, and then you're going to draw up the correct amount according to your order set. Now, a lot of sites are used to giving TNK for MI, so are quite comfortable. So a few red flags when you're giving it to a stroke patient: it's half the dose for an MI, so 0.2 milligrams per kilogram when it comes to dosing for strokes. Unlike MI, You don't want to give any other anticoagulants or antiplatelets in association with this drug. This is one and done for your patient. So when we talk to families, where do we start? We all know that time is brain when it comes to stroke. So the faster we can get this drug in, the better outcomes our patients will have. So your families don't have a lot of time to hem and haw and call a friend to ask them what they think. So you've built a little bit of a rapport with them. You're going to be supportive of them. We tell our patients that the biggest risk associated with TNK is bleeding. When we talk about bleeding risk, there's about a 6% chance that the patient will have some sort of bleeding, about a 3% chance that it'll be an intercerebral hemorrhage, and around 2% that it will be a clinically significant intercerebral hemorrhage. So TNK is a relatively safe drug to give. The other thing that is nice to know is that for every 10 people that get TNK, one person will go home independent. So in terms of scientific studies and numbers needed to treat, it's a very low number needed to treat with TNK to have a good functional outcome. Okay, time for a TNK roundup. Numero uno, TNK is now the Saskatchewan drug of choice. Although it's non-inferior to TPA, so much easier to give. This is the direction we've gone in. Number two, time is brain. Our goal is to get this drug into our stroke patients within 60 minutes from the time they arrive in your hospital. And ideally, 50% of our stroke patients who get TNK would get it within 30 minutes. I believe in you, you can do it. Number three, if your patient has gotten the drug and is now to get out to Saskatoon for mechanical thrombectomy, we want you to go fast. Ideally, they will be in and out of your hospital doors within an hour. Let's do this. Next, number four, no Foleys. A stroke patient doesn't need a Foley. If you look at the TNK order set, do you know what it doesn't have? Insert a Foley, because they don't need one. Now, use your clinical discretion, some will, but let's try and avoid them if we can. Number five, you don't want your patient moving around for kind of the first 24 hours post-TNK. It's just more of a safety issue than anything, but it also is a neuroprotectant. We want to not mobilize quickly after stroke. Number six, you got to get that post-TNK CT scan before you give any anticoagulants or any antithrombotics. We need to rule out intracerebral hemorrhage before we start the aspirin and Plavix. And number seven, please do not ever hesitate to call neurology if you have questions or concerns regarding your patient who has gotten TNK. They'll have already been on the phone to help determine if the patient is a candidate, but post-infusion or post-bolus, if you need help, just reach out. Most of our stroke neurologists are very, very wonderful, and I really like them. Yeah, and that's it. So today, I want you to give TNK quick, because you know what that will do? It will save lives and it will improve functional outcomes.